which is by Dr. York, will be presenting possibly a myth: early full enteral nutrition improves outcomes in ICU patients. Dr. York.
All right, so we're going to start with just a little overview about critical illness physiology and how nutrition might play a role in that. You know, critical illness, especially in the ICU setting, is associated with overall catabolism relative to anabolism. So just heightened muscle breakdown, glycogen storage breakdown, you know, really freeing up macronutrients for use in the adaptive response to the illness itself. And on the other side of that, there's also thought to be a resistance to some of the anabolic signals, some of the, you know, neuroendocrine hormones that lead to building up those tissues that are currently being broken down in the critical illness setting. So, you know, makes us wonder if there's, you know, the body has its own adaptive mechanisms to using its own nutrients from its own tissues versus absorbing exogenous nutrients that might be provided via nutrition. So overall goals in critical illness nutrition is to avoid underfeeding, which has been shown to be associated with prolonged ventilation, increased risk of infection and death, but at the same time, avoiding overfeeding, which is associated with essentially the same thing. So there's a fine balance between not giving enough nutrition and giving too much nutrition in critically ill patients. And then longer term outcomes largely focus on functional status. So the muscle wasting that occurs when patients are bedbound for so long in the ICU, being able to give them nutrition to hopefully avoid some of that muscle breakdown as well. And then, the concept of maintaining the gut lining just with, slow nutrition is also important in this setting. So key decisions, they're all number one, so they're all important. A, the route of nutrition, parenteral versus enteral. B, the timing of nutrition initiation, so early on in ICU admission or later on in admission. And then also the quantity. Are we going to give people less calories than what their metabolic rate would dictate, or a full caloric nutrition? And Dr. Freed gave me the go-ahead with a lot of memes, so just get ready for more in the later presentation. So some of the difficulties with critical illness nutrition research in general is that a lot of the early studies were observational in nature. So they took a group of patients, saw what type of nutrition they were getting in the ICU, followed them later, and tried to extrapolate associations between type of nutrition and overall functional outcomes. And so this gave a general idea of which nutritional strategies were preferred, but they were unable to answer more specific questions like the one we'll be addressing in the presentation today. And then, there's also a spectrum of people who are admitted to the ICU and who are considered, quote unquote, critically ill. And so being able to tolerate certain types of nutrition is going to vary on a patient-to-patient basis. And then lastly, a lot of the studies and even some of the RCTs that we'll look at later, they did exclude patients who were quite malnourished at baseline, or they had a very kind of imprecise definition for what constitutes a malnourished patient. So that is also difficult to kind of study. So this is just a meme of what I just said. Okay, moving on. So the first trial that we'll look at is called the IPANIC trial. So it's early versus late parenteral nutrition in critically ill adults, published in 2011. And it was studying about 4,600 patients across multiple ICUs in Belgium. And to just give context to this study, at this time, the European Society for Enteral and Parenteral Nutrition, they were recommending early parenteral nutrition supports in critical illness, while at this time, the American societies recommended more of a hypocaloric approach initially for these patients during the first week of admission. So this trial really sought to compare the two, kind of the European versus American approaches in terms of the number of calories and how early on patients were getting them. So each group started on day 2 with hypocaloric enteral nutrition, so sub-caloric goal. And then the early group received parenteral nutrition to supplement on day 3 to reach full caloric goal, while the late group did not receive the same parenteral nutrition support until day 7. The results of this study showed that receiving early parenteral nutrition support to reach full caloric goals by day 3 led to increased length of ICU stay, which was the primary outcome, as well as inferior results relative to pretty much all of their secondary outcomes, such as nosocomial infection, duration of intubation, duration of hospital stay, basically everything that they studied. However, notably, mortality at 90 days was no different between the two groups. But the author's overall conclusion was that early parenteral nutrition support to reach full caloric goal was inferior to supplying the same calories later on in the illness course. The next trial is the calories trial in 2014. And this examined the effects of the route of nutrition, so parenteral versus enteral, across 2,400 adults in England, across several ICUs. So they were randomized to receive either parenteral nutrition via a central venous catheter or enteral nutrition via NG or NJ tube. The nutrition goal was the same, 25 kcals per kilogram per day, started within 36 hours of admission. And there was no difference in all-cause mortality between the two groups, although there was increased vomiting and hypoglycemia in the group receiving enteral feeds in this case. So the authors concluded that early support via parenteral nutrition is neither more harmful nor beneficial. So the route does not matter, essentially. So this kind of brings up, these two studies kind of indicate a point here, which is if the route of nutrition support doesn't influence outcomes, which we just saw, but the ASPEN trial demonstrated harmful effects of full parenteral nutrition, then it suggests that it was the full component, the larger number of calories, that were responsible for the harmful outcomes that were seen in the first trial. So we need more studies. The PERMIT trial in 2015 sought to answer whether restricting calories, so permissive underfeeding approach, influenced 90-day mortality amongst ICU patients who had an expected stay greater than 72 hours. This underfeeding group received about 40 to 60% of their caloric requirements, while the control group received 70 to 100%, and their daily requirements were determined by a BMI-based equation. And the caloric intake also notably did include calories from things like propofol. If any medicines were dissolved in dextrose-containing solutions, all of those additional sources of calories were taken into account, as well as patients who were also receiving parenteral nutrition. So this study found no difference in outcomes between the underfeeding and the standard feeding group, although blood glucose was significantly higher in the standard feeding group. And then a small post hoc analysis of the patient population ended up revealing a higher need for renal replacement therapy amongst the standard feeding group. But as I put here, the number needed to treat with underfeeding to prevent one incidence of renal replacement was 24. So the authors of this trial concluded that moderate caloric feeding, so sub-goal, with maintenance of daily protein requirement, I guess I didn't mention that before, both groups received the same amount of protein, was not associated with any reduced mortality. The Target trial in 2018 examined almost 4,000 patients across ICUs in Australia and New Zealand. This trial sought to answer whether an energy-dense enteral formula versus a standard caloric formula influenced 90-day mortality amongst intubated ICU patients. So the intervention group received a more energy-dense formula, so just more calories per milliliter than the control group, though they were fed at the same rate. So the energy-dense group ended up getting about 1,900 calories per day compared to 1,300. And this trial also found no difference in 90-day mortality. However, the higher density nutrition group had larger residual volumes, more regurgitation and vomiting, and a higher use of insulin than the standard formula group did. So the overall conclusion here is that energy-dense enteral nutrition did not improve mortality amongst intubated ICU patients. And then the EDEN trial was a trial in the United States that examined 1,000 patients with acute lung injury. So we're intubated within 48 hours. The intervention group received more of a trophic feeding approach. So again, kind of a sub-goal feeding at 20 kilocalories per hour. although it was advanced to full feeding if they were intubated at the 6-day mark. And then the control group had full feeding, 25, I guess the units here are different, but 25 milliliters per hour, advanced to goal as quickly as possible. This also showed no difference in ventilator-free days, no difference in 60-day mortality, infection rates, or organ failure-free days. But again, the group that received a slower rate of feeding had less regurgitation, less vomiting, and fewer residuals than the control group. So again, the trophic feeding strategy within the first 6 days did not influence mortality or ventilator-free days in the study. The populations of the last 2 trials were also followed for the next year or so afterwards, and a couple other studies investigated more functional outcomes. So how are these people doing at home? Are they back to their baseline functional status and activities of daily living? And it also found no difference in morbidity or overall functional status at the 6-month or 12-month marks. These are just some of the figures there. The one on the right, the legend is kind of cut off a little bit, but the green is essentially the group that received the least amount of nutrition. Or no, sorry, the green is colors or functional status, and you can see it stratified by the amount of nutrition they received on the left. So some of the professional societies, the European Society and the American Society for Parenteral and Enteral Nutrition, have offered some critiques of these RCTs that we just looked at. So one that I kind of touched on earlier in the presentation was not including patients at a higher risk of malnutrition. And so the PERMIT trial was re-examined on a subsequent analysis that showed heightened mortality amongst the subgroup with the lowest prealbumin. So I think we could probably also have a talk whether prealbumin is a really good indicator of this situation, but I see Yuli in the back, maybe she can touch on that later. They've also critiqued whether these studies were providing insufficient amino acids, but interestingly, further analyses of these same trial populations showed that a lot of the excess amino acids that some of the higher protein groups were receiving ended up just getting wasted, so not functionally being utilized by the body in any way. And then some analyses have actually shown harm between amino acid dose by parenteral nutrition. Then lastly, as I mentioned, the calculations to estimate energy need are often weight-based, and none of these studies used indirect calorimetry, which is measuring kind of venous gases to calculate how much, what the resting metabolic rate of these patients are. So studies that use that to maybe get a more accurate need of what the patients are needing could be used in the future. So we can revisit again the sort of physiology here and whether providing nutrition at a full dose too early affects this anabolic resistance aspect of the physiology that we kind of touched on earlier, that maybe we're providing too many macronutrients that end up just leading to higher circulating levels in the bloodstream that are not able to be adequately utilized by the body while it's adapting to their critical illness setting. And maybe people become responsive to exogenous nutrition just later on in the illness course. So the American Society for Parenteral and Enteral Nutrition updated their guidelines in 2021 after all of these RCTs had come out. And as we sort of saw with all the data, they decided that the route of nutrition does not change outcomes, which we saw with the first trial that we looked at. And this was based on high quality evidence, and they felt very strongly that this was the case. They showed no difference at all in clinical outcomes between higher or lower energy intake, though the quality of evidence was a little bit weaker here. And then again, as we saw, no difference in clinical outcomes by adding early parenteral nutrition to meet energy targets. So these are just some forest plots taken from their overall meta-analysis as part of their recommendations. So this first figure is the difference in hospital length of stay between the higher energy on the left versus lower energy groups on the right. Shows no difference. The second is hospital mortality, which is also no different across all their meta-analyses. And then 90-day mortality here as well, which one study showed higher energy where the other ones showed no difference overall. So I think throughout all these trials, we've been able to demonstrate these concluding points that providing nutrition parenterally versus enterally does not influence outcomes amongst critically ill patients unless there is an obvious contraindication to either. I should have said either route. Caloric dose, providing full caloric nutrition does not improve outcomes, and when provided enterally, often found greater levels of gastrointestinal discomfort. I think the other thing that was brought up with these trials is that there wasn't really a standard definition of high versus low energy intake. Some, estimated percentage of overall need, but there was often quite significant overlap between the amount of calories that lower energy groups and higher energy groups were receiving, such that some studies, the high group was actually the low group on some of the other studies and vice versa. And then later, future research in this area should probably include, better indication of baseline nutritional status. So some patients who come to the ICU remarkably undernourished might need different approaches than those who, maybe younger patients who have a bit more nutritional reserve. My sources.
Any questions or comments for Dr. York? Nope. Nobody? I had one quick comment. Did you have anything? Yeah. So I put this up here because, there's an old adage, right? Old wives' tale, and, feed a cold, starve of fever. And I think that, when people are really sick, certainly critically ill patients, they don't really want to eat. They're not hungry. And that can go on for days and days. And it's probably our body kind of telling us something, perhaps, I don't know, that they don't really need any, that much nutrition right off the bat. This saying, I was looking up where this came from. Hippocrates thought that starving the fever was a way to starve the disease. He said, the more you feed diseased body, the worse you make it. And the first known publication of this adage was in 1574, so it's been around a long time. Fasting is a great remedy of fever. So like I said, I think people generally don't want to eat when they're sick, if they're not intubated and can actually tell you that they're not hungry. And so, in medicine in general, and especially in critical care, I think in the past, certainly when I was training, and I think even now today, we all, our goal is always to bring, make people normal, right? You want to make people euboxic, right? You want to make all the little boxes normal. You want to normalize everything, but it's become really clear to me, and we could probably do a Mythbusters on this in the future, that at least in critically ill patients, normal is not always the best. Normal amount of nutrition is not necessarily the best for critically ill patients. I think that's what this shows. And I think there are a lot of things that we do in critical care now where normal is not what we shoot for, at least initially. Ultimately, yes, we want them all normal, but in the beginning, and that goes for everything from blood pressure for MAPs. A MAP goal of 65 is not a normal blood pressure. And that's what we use for shock. So there's a lot of examples of that we don't necessarily shoot for normal. So I don't know, Yuli, you have any comments in the back? No? Okay. All right.
Had seen the Is it on? I was just curious if you had seen the Nutria 3 trial.
No.
Okay.
Can you tell us about that?
I can try, but I can, I mean, they're essentially looking at it right now. It's a randomized controlled multicenter open label trial of low calorie, low protein feeding versus standard calorie, standard protein on outcomes in ventilated critically ill.
Okay.
I want to say it got halted for some reason, but I can't quite remember, but I know it's registered right now. So I'll be really
Okay.
interested to see
Yeah,
what comes
sounds
out.
like we'll have to look forward to seeing that when it's published.
Yeah.
Okay, well, I think it's time to vote. So is this a myth? How many people think this is true, that early full nutrition improves outcomes in ICU patients? How many think it's plausible? How many think it's busted? And we had one plausible there. Dr. Fitzgibbons is not convinced.
Further research is needed.
Further research is needed. All right, it looks like most people think it's busted, so you're outvoted. Just tap.